Welcome to this second week of Psychiatry and Overview. In the last week, we looked at the basis of human behavior briefly. We just did a bird's eye view of the whole thing. Now, this week we will try to look at the tools which we use to assess people in a clinical setting or research in behavior. So, the basis of this is what we call a mental status examination, because obviously we have to interact with people to judge whether their behavior is normal or not normal. People are brought to a psychiatrist or a clinical psychologist for to be assessed whether they are behaving normally or abnormally. Now, the basis of decision of normal and abnormal we will talk about in the other part when we talk about classification. But how do we, without using the technology, how do we judge whether the person is having some problem or not? And like in other medical examinations, obviously it will be useful for people who are into clinical setting, but also for people to understand how psychiatrists reach a decision of whether the person has a illness or not, or it is just a variant of normal behavior. The process of this is called a mental status examination. Now, this mental status examination has certain descriptions of human behavior which indicate the state of the mind, and there are same things which everybody has, like thought, like emotions, like behavior, the appearance, the memory. But how do we assess this is and the difference and the range of behavior, the range of experiences which the mind is undergoing, the type of experiences are called phenomena. So, phenomenology is the window by which we can assess the person and reach a decision whether the person is having a problem or not. It comes from philosophy actually, existential philosophy, Karl Jaspers and others who devised this phenomenology, and which still remains the standard tool of a clinical assessment, which a psychiatrist should be well trained into, like a physician should be well trained into auscultation, palpation, observation. Similarly, a psychologist and a psychiatrist, but it is good for other people also who are doing these courses from other disciplines to look into the process, because obviously it is a framework which psychology and philosophy has provided us, and it helps in understanding into the different mental states. So, mental status examination, so the first and foremost you observe, you listen, and then you ask, not necessarily in this order, because it will otherwise make a very cut and dry exercise which cannot work with human beings. So, all these three things sometimes have to be done simultaneously, sometimes in sequence, sometimes parallelly, and this is the human skill which a psychiatrist and a psychologist are supposed to develop. A mental status examination, part of which defines the normal behavior, part of which defines the abnormal states of mind. This is a pro forma which I will just run through, developed by NIMHANS, National Institute of Mental Health and Neurosciences, one of the premier institute of psychiatry and neurosciences in India. So, obviously when you introduce yourself to somebody, you have to ask the name, introduce yourself, ask the name, education status, socioeconomic status. If somebody is accompanying the person, and I am not calling that person a patient still, because we have not established whether that person is patient or not, they are normally brought to us. Everybody who is brought to a psychiatric clinic is brought with a problem. Now, this problem is a altered behavior which may be causing disruption in the adjustment with the people or within himself, or the person is not performing optimally, they can come up with common problems. So, you check who is the informant, it will be a family member or a friend, age of the person, sex of the person and occupation. This demographic data broadly gives you a context. As I said in the last slide in previous lectures, what makes us human is not the size of the brain or just the basic activities that all animals do. It is the context of your behavior which actually makes us define whether it is normal or abnormal. A soldier firing on the border in a war may be normal, but a soldier who stands suddenly enters a restaurant and starts firing will be abnormal. So, the context of human behavior is very important, that we all should remember, whether we are in research or in teaching or in interactions in your business. And so, this is something which we have to always know. So, this demographic data, suppose a person who, let me give you an example, suppose a person who is not gone to school, is coming from a village and suddenly enters your room and has not trained in English obviously, and he starts talking English with a broken English here and there, which is unusual for the person. So, this background information will help you in understanding the context. So, everybody will come with the complaints, but so what are the common complaints people come up with? Maybe if they bring a teenager to you and say that he is not studying, he is not going to school, that may be considered an abnormal behavior by the parents. So, when we are looking at the phenomenology, we are looking at the expression of the behavior, what is actually happening. At this point, we will not be too bothered about why it is happening. So, if somebody comes and tells you that the person is not going to the school and the kid tells you that I am not interested in studies, that is the phenomena, the lack of interest. Now, the not going to school may be because of a broken leg, or the lack of interest may be because of maybe he has a weak eye and he is not able to see the board. That we will have to discern as we go along collecting the history. But before that, let me tell you about an experiment. A professor took his couple of students to a psychiatric hospital, and they all complained that they were hearing voices, which is called hallucinations, in the absence of any true source of sound in the vicinity. And they all were giving diagnosis, but they all were feigning it. So, the difficulty is very difficult to understand if a person is complaining the real cause, unless we really go deep. But that is the second level of inquiry. The first level of inquiry is what is the complaint. Somebody who is a quiet person and suddenly becomes very abusive, they may be brought with this complaint. So, first thing is the complaint itself. Second, you will have to check what is the history. It is in days, in hours, in months, or it has been for years. How did it start is the onset, because some illnesses start and grow slowly, which is an insidious onset. All medical students will know this. And some illnesses may start acutely. Acutely means sudden onset. Now, the sudden onset may have different causes, not that all illnesses have to start insidious, but some long term illnesses can suddenly, they go slow and start slowly and progress. Whether there is a precipitating factors, whether the illness started with some factor which has happened in the environment or body, a physical illness, a mental illness, a trauma, or some other event, because some of these illnesses, psychiatric illnesses, as you will learn later, have very clear cut onset with environmental stress. Some of the medical illnesses can cause psychiatric illnesses. Course of illness, whether once it has started, is it progressive, is it worsening, the symptoms are worsening, or after worsening suddenly they have reached a plateau and they are going on like that only without any further change in intensity, or they are improving, or it is a continuous illness for the duration whatever they have told you, or it is an episodic illness, like it happens, it switches on, it has a certain course, then it automatically improves, which we call remission. Now, these are important factors in deciding on what illness we are talking about, what mental state we are talking about, whether we are talking about a state of the mind which where suddenly uh, it has suddenly gone into one state and it is never coming back to the original state of mind, or it is like a phase. For a phase, the disruption is there and then it becomes all right. Like for some children, like in an illness called mental retardation, it happens and then it happens. It's just that gap between intelligence and age continues. Whereas something like dementia in old age, where there is a progressive decline, it's a very, very progressive illness. A bipolar illness, mostly it's an episodic illness. Right. Along with it, we have to look at what impact it is having in the life of the person, in the work, in the relationships, in the normal flow of life, which is a hallmark of normalcy. Now, one person's normalcy may not be the other person's normalcy. A sports person doing a marathon every day is normal for him, but it may not be normal for an office clerk. So, depending on their context, which you get from the demographic information which you have already collected, what exactly this set of symptoms is doing. Any past history of illness. So, this you will have to check whether if it is a continuous illness, you will have to check from what time it started, whether there was any illness or disturbance before that. But if it is an episodic illness, again the past history would be before the first episode. If you take a present episode, somebody tells you that this person is disturbed for 15 days, you will have to really ask whether there have been previous episodes like this, and then go back to the first, whatever information you can gather, and family history, because we have talked about genetics. So, if genetics, the behavior of human being is like a template which comes from your gene, the illnesses we will describe when we talk about illnesses also have their genetic predisposition. And it is more or less established that the certain illnesses, they are like run in genes, and it is not necessarily that every person will have it, but if there is a illness, suppose for certain illness, a normal person in whose family there has been no illness, the risk is 1%, and if somebody in the family has had a illness, the risk will go up to 10%. So, if somebody in the family has had a similar illness, you can narrow down your search. Personal history, birth and early development, whether the person was normally intelligent, development was normal, whether there was a predisposition in the temperament during the childhood which has predisposed, a lot of linkage, what we call externalizing syndrome, disturbances in childhood because of the environment or because of illnesses or because of genetics or epigenetics. The lot of these kids who have disturbances in the developmental phase are known to develop psychiatric illnesses as they grow. Because one thing which we should mention it here is that the brain, once it starts developing within the womb, initially grows, number of neurons grow much higher than what is required till a certain age, say around teenage of 14, 15, 16, and then there is a pruning which starts in the brain, and the pruning is that the synapses decrease till around, it starts around 16, 17, and then all its life the brain keeps pruning along with its neuroplasticity. Neuroplasticity means that if the brain is damaged, it will always try to reorganize and restructure itself. Some neurons which are specialized can always take over the function of the other neuron. It is very well known, but largely the pruning happens and brain shrinks, but it does not shrink enough for most people to lose their intelligence or their skills. It shrinks more in some other illnesses, and that is why illnesses come. This is the developmental model of illnesses where the brain shrinks more than required. But if you look at the development of the brain with this 10 to the power 11 neurons, it is like environment challenges the brain responds to the environment, and in this critical dialectics, the brain forms new and new networks and synapses, and that is what learning is all about. So, once brain is challenged with something, with the environment, the brain tries to overcome it, in the process forms new synapses, new skills, new memories, moves on till the next challenge comes. So, these are critical period of developments which keep happening at various ages, and psychology also defines a lot of the development, like people like Piaget and Freud, they gave various theories of critical development. Probably what they were telling psychologically is the corresponding critical development of brain during teenager when the hormonal changes are happening. So, it is important to know what was happening during the behavior and what was the environment during childhood, because that will tell us whether the brain successfully resolved those critical challenges and critical period and formed the normal synapses like everybody else. The good thing is that because normalcy is also defined by a common pattern of behavior, statistically normal, most people are behaving in a certain way. That means the brain has this synapse formation in brain, the network formation in the brain is actually the pattern of response to the environment which most people develop. There may be range of aberration and change in behavior, but most people would respond to a certain stimuli in the same way. That is the commonality of human race. That commonality is the normalcy of the human race. So, within that commonality there may be variation, but any aberration of development, suppose during a certain critical development phase the environment is not conducive. Suppose in the first 2 years of life the brain is not receiving that trust and security and the love and warmth from the environment, it will become anxious, because the brain will always be insecure, and these insecurities are one which people show later in life. This is more or less a very robust thing which we have learnt over time. Physical illnesses also disrupt, educational history which is obviously related to the growth of the brain, occupational history, menstrual history, sexual history, all these things which go on in making a normal person. But this is important, because any aberration we find in any of these should be correlated later on to the abnormal behavior, may not necessarily be causal, may not necessarily be directly linked to why it is happening, but definitely to contributing to this illness, because we know psychiatric illnesses or abnormal behavior do not have a single factor. Rarely they have a single factor that okay, it is like this event, now you have an injury on your leg and your bone is broken. It is not like that. The brain bone, when it breaks, it may have multiple, your tendency to develop illness, your environmental stress, your genetic predisposition, your stress. Okay, marital history, use and abuse of drugs, because drugs are chemicals which we very well know are disruptive into the brain mechanism, alcohol, cannabis, cocaine, all of them. Pre-morbid personality, which includes attitude towards others, attitude towards self, moral religious attitude, mood, leisure activities and coping style. All these are important, because all these things actually contribute to making a person. Now, when we know, we get all this history, and meanwhile when we talk about mental status examination, while history taking and mental status examination may not be separate, although for convenience sake we are putting it in a categorized manner, but while we are gathering information, we are knowing lot of mental status examination, maybe something patient will answer, some things the informant will answer, but we are also at the same time observing, we are looking at the general behavior, we are gathering his thought process, his religious belief, his working style with. So, you understand this psychiatry examination is a time consuming process, and the first and foremost is you should be with the person, not deal with the person as from top down thinking him of as a patient, but also try to look at the person, because that will help you take a clear decision. So, once you have taken this history, out of this history and other things, we can get to doing what we call a mental status examination. So, what do we look at it? First, in a given society, there are certain ways of dressing, there are certain ways of behaving, there are certain ways of addressing. So, you look at the general thing, you look at the appearance of the person, given the education status, given the background, given the socio-economic status, given his religious belief, given his socio-cultural belief, there is a certain behavior and appearance which is expected. So, that is the first thing which will tell you whether the person is in sync with the environment or not. Second, what you will have to look at is at the activity level and the attitudes, like an appearance, appropriateness of dress, as I said, general demeanor. If a normal person who has been normal and docile suddenly bounces into your room and is very aggressive and threatening without any reason, without any background of knowing you, obviously that could be a sign of an abnormal behavior. When you talk of motor behavior, you see the way people walk, this is all common sense thing, but you have to develop eyes to know all that. You see the way people walk, some people walk very grandiosely, some people are that haughty walk which they have, some people are very, very timid, hesitant. There may be a problem with walk because of a neurological thing, like a Parkinson's patient, a psychiatric patient may have a neurological problem, has a very, very different typical walk, short shuffling steps, or somebody with a frontal lobe damage has a different type of walk. There is a problem with initiation. Psychomotor activity, there is a motor activity and there is a psychomotor activity. Motor activity is like somebody who is sitting on a chair in front of you and there is no reason to be anxious except for his internal reasons or what he is thinking. He is very fidgety, touching these things, catching the edge of the chair or tremors. These are all motor activity, restlessness, agitation, whereas psychomotor activity is certain goal directed activity. All of us, when we sit and talk or stand or talk, have certain amount of psychomotor activity going on within us. All of us do it unconsciously, because see, when I am talking, I am moving my hands. Why am I moving? If you ask me immediately, I may not have an answer, but that is the habit or the way I have evolved. But if psychomotor activity is drastically reduced or it is drastically increased, like a person who comes and sits and suddenly starts fiddling, takes a pen and paper, starts writing without provocation or without being asked to, or start fiddling with your paperweight, or suddenly goes and switch on or puts off the light, that is a sign of increased psychomotor activity, which is a hallmark of illnesses called mania. Increased agitation can happen in neurological illnesses like Parkinson's or cerebellar dysfunctions or anxiety or any other abnormal movements. Lot of neurological illnesses have, like in Huntington's chorea, there will be suddenly dance like movement or pill rolling tremors in Parkinson's, or there may be tics, sudden jerky movements, episodic jerky movements of certain areas of body. All this has to be observed. But what is also important now, how will you judge all this? First and foremost is obviously establishing a rapport with the patient. What is a rapport? Rapport between any two person is where people are ready to share things with each other. Now, if a person does not form a rapport with you, obviously your rest of the interview will not, and often people find this difficult. If you do not see whether the rapport is good or bad, and then later on you say you could not gather information, it is because of the lack of rapport. Now, lack of rapport itself may be a sign of abnormality, because ideally when you are brought to a doctor's clinic, you are supposed to tell things, and so if a person decides not to tell, it is like difficulty building rapport, and some people will walk in and become very friendly with you. So, both ends may be a sign of illness, like in a mania, a patient who has mania, who is disinhibited and talking too much, and it just becomes very friendly with you, and you will find it very easy to establish rapport. But if somebody tells you that 15 days back he was not like this, so you will find this is a sign of abnormality. So, having said this, so rapport building may be normal, but we all with experience in dealing with people, we know that a gesture of smile, how are you, talking about other things, builds a rapport when you find things of common interest. Eye to eye contact, whether the person looks into your eyes and then talks, is a good sign. On a window, eyes are windows to mind, it is very true, but one has to really learn to look into that window. Eye to eye contact is something which can tell you whether the person is actually inclined to talk to you. And eyes can tell you, can differentiate between lot of illnesses, because you know what anxious eyes look like, and you know the where depression is there, the people are look down, downcast eyes, you can, it goes on with your face. Whereas in something called negative schizophrenia, where the person is totally blank inside, not totally blank, but it's in a total evolution, not interested in talking, flat mind, not many thoughts in the mind, still the eyes may not be downcast, they may be normal. There is a fine subtle differentiation, but so eye to eye contact is poor or good or fleeting, because a maniac, the patient with mania. So, what you call a maniac, I just uttered this word, is different from people having mania. So, maniac is a literary, it's a metaphorical term, but he has become maniac. But mania as an illness is different. A person with mania will have fleeting eye to eye contact, because he will not be able to put attention into one thing, whereas a normal person may have slight distraction here and there, but largely he will look at you. So, rapport and eye to eye contact will give an idea of the mind state of the person, whether he is interested, he is there talking to you or not. Speech. So, after eyes, the only way we know what the other person is thinking is thoughts, and thoughts are expressed through speech, at least in most condition when we are talking. There are other ways of expressing your thoughts by painting and writing and all, but those are different things. When you are talking to a person, you look at the speech. So, what do you look at in the speech? You look at the rate, whether the person is really, at what rate his words are coming out. Especially in mania, people are very voluble, the control is gone, and they will be uttering a whole barrage of words. Whereas in depression, even the normal output of words would have been decreased. In schizophrenia, in undifferentiated type of schizophrenia, where people do not have much verbal output, spontaneity, whether you have to prod the person to talk, or the person would talk and is willing to share the information on his own. We know there are some people who talk spontaneously, some people have to be prodded. Introverts often do not talk, and they have to be asked and told. Whether there is a personality issue, whether this is an illness, depends on whether he has become like this or he was always like this, as we have discussed. Whether the thing is continuing from part of the personality or intonation, in what tone the person talks. That is a reflection of the emotion, irritability, anger, sadness. We can make it out from the, similarly volume. So, all these things are not separate. You do not have to go one by one and check rate or check spontaneity or check intonation or check. With the overall output, you can judge. It is a matter of skill again, and it is a matter of exposure to various people to differentiate between what type of speech. Now, one good book which is there is called Fish's book, FISH apostrophe S. It is a book on phenomenology, which gives a good description of all this. But largely speech, eye to eye contact, rapport, general appearance, behavior, in keeping with the context and in keeping with the personality, in keeping with the background, with the previous history which you already have, and the personality, it will give you an idea whether all this is going in the right direction, which is what we call normal, or is it something else. Then what you have to judge? Now, there are illnesses which are in psychiatry, which are basically disorder of mood, what we call bipolar mood disorder, or there are disorders of thought and perception, or there are disorders of cognition, or all of them existing together. So, once this general thing of speech and appearance, behavior and rapport and eye to eye contact will give you an indicator of what exactly is happening. But then you have to still go deeper and really find out mood versus affect. Mood is a more or less slightly longer sustained phase of emotion. Affect is slightly, if you take it in a cross section. So, mood generally he is a moody person, means what do we think, but that is a common sense thing. He is a depressed person, means that largely his mood remains depressed. He is a happy person, largely his mood remains happy. Affect may be cross sectionally, when you are talking for 1 hour, he may be happy at that time or sad. So, we have to differentiate between that. When somebody says this person is extremely happy, so what you have to check, whether he is happy now in the last 3-4 hours, one day, or generally he is a happy person for last 1 week. So, when we assess, we normally talk of immediate cross section, what is happening now, which is affect, and what is happening to his mood in the last 1 week. Roughly, it is an arbitrary thing, there is no scientific proof to it, but largely it remains. So, what we have to look at the quality, what are the quality of moods? We all know there is a whole range of human emotion, although we know they are primary emotions, but there are secondary complex emotions like love and altruism and all that, but primary are angry, fearful, sad, happy, in rage. These are the largely. Now, sometimes what will happen in the same interview, you may find a lot of fluctuating moods, which is also fine, because you do not have to fit the person into your theoretical knowledge. What you will have to do is look at the person and describe his mental state. So, do not worry about, okay, this is the word I know, whether it is fitting into that. Sometimes things may not fit. So, what is the subjective versus objective mood? The person may say he is happy. A lot of people, when you are sad, and if you ask them why are you sad, they will deny nothing is there, I am fine. So, you do not look at them and believe what they are saying. If they are saying they are happy, that is a subjective report. Objective report may be that he is appearing sad. We all know who is sad and who is happy, because if you remember from the previous module, previous talk, I told you about the mirror neurons. So, our mirror neurons know that this person is appearing sad, but he is saying I am happy. Now, if he says, do not immediately think that he is having some split of emotion and thought. This you have to judge whether he is just denying it, and if you continue talking with him, do not decide on 1/2 a second. If you continue talking, his sad mood will appear. Whether it is congruent versus incongruent. The congruent versus incongruent means his mood is in keeping with his thoughts, or it is not in keeping with his thought. If he is talking about somebody's death and he is giggling, that is certain incongruency between what he is saying and what he is feeling. But if person is talking about, say, somebody is after my life and is expressing fear, it is congruent. It is congruent between his inner state of thought and his mood. There is a congruency. So, congruency and incongruency is with the appropriateness from within, whereas if you say it's appropriate versus inappropriate is in the external circumstances. So, if I am talking about somebody's death and I am sad, which is congruent. If I am talking about somebody's death and laughing, it is incongruent. If normally most people, when they lose something, in a situation of sadness, if I am feeling sad along with thinking about this thing, then it is congruent. But appropriateness is with the external environment. Suppose if I am standing somewhere where somebody has died and I am laughing, that is inappropriate. I am supposed, our mind has trained over millions of years to, as I use the word again and again, context. Our mind has trained us to behave in a certain way in a context, and that is a universality and commonality of training. All cultures, laughing is laughing, crying is crying, death people cry. So, that is appropriateness. If somebody is behaving inappropriately, so that is an inappropriate mood. So, mood generally has to be assessed on these things. Affect is then and there. What is the intensity? Somebody may be extremely sad, extremely happy, extremely angry. Whether that is appropriate or not, we have to check that. What is the range? Whether within a conversation, a general conversation, if you are not focused on one issue, people show range of behavior from happiness to sadness to irritability to mood, so on so forth. Reactivity. So, that is the range which shows. Reactivity is that when you say something, whether the other person is showing appropriate reaction at all or not. You may suddenly tell a joke and the person may keep sitting flat. So, either the joke has fallen flat or the person is not reacting, or if this, so you have to not only keep talking about the patient's problem, you have to talk about other things also to evoke some reactivity from the person. So, if you evoke reactivity, then that normal range also gets exhibited. So, you have to see whether the person is, like in depression, people will react less because they are so absorbed in their thought. Like a person with obsessive compulsive disorder may not be just worried about his obsessions. A person with schizophrenia may not be listening to you, and he may be actually lost in his own hallucinations. So, he will not show the normal reactivity and range. All these things will indicate whether that person is actually in touch with you, although he may be looking at you, if he has built a rapport, then he would show a normal range and reaction, appropriate mood, congruent mood. So, which are the signs of normalcy? Normal people react to normal things, to joke and or to a sad news or to a worrisome news, and they exhibit a normal range. Intensity, obviously. So, mood is again euthymic, which is okay, normal mood. Angry, euphoric, person may be extremely happy. Apathetic, maybe he may just not be interested in what you are saying. Dysphoric means not liking. It's slightly on the spectrum of dysphoria to total sadness. He may be just not liking what you are saying, or apprehensive, very fearful or suspicious of the thing. There is another word which I should mention here called elation. There is a difference between happiness is a subjective state. Somebody may say I am happy, fine. Euphoria is slightly more than that, which is slightly more happy, which is a sign of hypomania. Mania is elation. Elation is it is infectious happiness. The person is happy and laughing, or just happy, and it is so infectious that you will, whether you want or you do not want, you will. That is what comedians do. No, but the comedians do not do because they are acting. It is not that they are elated, they can create elation, or a song may put you in elation, and elation is one of the phenomena which often happens in dances and all. When people are dancing, the music puts you into a certain elated mood, and that elation does not restrict itself to the mind itself, it goes into the body and everybody starts that is what the, but it is not abnormal. That dance elation in a situation is now why? Because of the context. So, in a marriage where people are dancing on the beat of the drums, that is normal because the context is like that. But a person who suddenly is sitting in a classroom and suddenly starts dancing, and he is so elated, and 5 other students start dancing. So, maybe that one who is having a illness and rest of them got an infectious elation, right. So, next important thing, and see all these things are intertwined. Do not think they are that behavior and my look and my rapport, my reactivity, my range, my mood, all is separate from my thought. They are all linked. That is how the brain connectivity goes on within the brain. And even though maybe it is modular and parallel processing, but it still keeps a sense of unity. So, what do you look in the thought? You look into the thought form. Normally, when we are talking, our one thought has a connection to the other thought, and to the third and to the fourth, and that is how we make coherent logical conversations, monologue or dialogue. That is called the form of the thought. But there may be a disturbance in the form, that my one thought may not be linked to the other, or it may be just linked. Some of them may be linked, some of them may not be linked, I may be talking something else and then suddenly I move on to something else. That is called loosening of association. In extreme cases, it can be what you call a formal thought disorder, which is a hallmark of schizophrenia. Formal thought disorder can be a positive formal thought disorder, where in between this loosening some new concept comes up, or a negative formal thought disorder where there is the whole poverty of content. That the person may be talking for very long in an open-ended question, in an answer to the open-ended question, but nothing emerges out of it. There will be no content. What we call a inane thing in a normal conversation may be a negative formal thought disorder in The second thing we look at it, but it cannot be judged with a open and closed ended question. How do you feel? He will say, I feel good. That you cannot decide on this, because formal thought disorder obviously you are looking at the form and the coherence of the thought process. So, you have to have a large sample of speech, for which you need some open ended questions and which per person can talk at length. So, you look at the stream. The form is how the whole thought process is structured. Stream is the flow, not in the skeleton sense, but in the sense of function. So, what do you look? The person may have circumstantiality. If you ask some question, for example, what is your plan for today? The person may take a very tortuous route to reach that point. He may start talking, okay, I have a plan for today, but yesterday when I was there and day before yesterday somebody came to my house, he told me whether I will meet him day after tomorrow, and I said yes, I called him yesterday, and he'll reach the end, but he'll take a very tortuous route which may actually bore you. Tangentiality is different. Tangentiality is that person may be talking suddenly, okay, I have a plan today and I need to go to United States after 6 months, and it's a totally, from plan he must have taken off a tangential route. It's easy to understand. Thought block is again a sign of schizophrenia, where a person is thinking and for few seconds there is a total block. The mind goes blank. It's one of the pathognomonic signs of schizophrenia, and when the thought resumes, it's a new thought altogether. Now, if a person suddenly mind goes blank, it can go blank because of the anxiety, but person will pick up the thought link from the previous thought. So, if I get a thought block, suddenly I can't think for a second, but I still regain the previous thought, it will not be thought block. Thought block is like your mind suddenly goes blank, it is extreme anxiety provoking, and you start from the fresh thought. Flight of ideas is a hallmark of mania. They can take off from anything, any sound, they can link one sound to another and go to another thought and just take off to another world altogether. If you can look at this, I was home and now I am here. I felt some chest pain, so I told my son and he called an ambulance, I am here. This is normal. Okay. I was home, I felt some chest pain, so I told my son maybe you know him, he is a doctor too, he always worries so much, finish. What was my point? Oh yeah, he has gone into a different trajectory. I was home, I felt some chest pain, so I told my son is really great, I finally settled down and have some children. Do you have children? So, this is tangentiality. He has just come here, gone to tangentiality, whereas the previous one was, if you look at it, circumstantiality. It will go around the route, come back here. This was tangential. Okay. So, other thing by echolalia, like they repeat the last word, which is most found in autism and other illnesses. Neologism, new words, either old words used in new context, which is not usual for people, or new words altogether. Now, Shakespeare introduced some hundreds of new words, which we can call neologism, but obviously he created the context of it. Perseveration is that when even if the question is shifted, people keep responding the same thing. It is a sign of frontal lobe damage, that when you ask something, okay, what did you eat? He will say bread. Where did you eat? He will say bread. When did you eat? Bread. So, this word, this is called perseveration. Sometimes the ideas can persevere. The same idea keep on thought blocking, as I have already told you. Content. The content of a thought can be overvalued ideas. Like somebody believes that it's very fine line between overvalued ideas and delusion. But delusions by definition, overvalued ideas, people take one or two ideas in their lifetime and give their whole energy to it. And it is not a question of right, wrong, good, bad belief. It may have some rooting in reality, but that idea takes over most of their life and ideas. Whereas delusion is a false fixed belief arising from one's own mind and which has a morbid basis. Now, the morbid basis is, I can just clear it by example. On what basis that person is believing, that itself is implausible, not impossible, implausible. Implausibility and morbidity can be defined. Let me give you an example. Somebody believes that my spouse is having an affair. Now, this is pretty possible. Somebody's spouse may be having an affair. But if you ask this person, how do you believe? They will have, without any concrete proof, they will have a belief. Even if there is a concrete proof that somebody may be really having an affair, the basis on which they believe is morbid and implausible. Now, what is that? That is that I know my wife or husband is having an affair because when I come home and I am sitting on a dining table, they are putting the knife pointing at me. Now, this is like the morbidity of it. How do you believe? Because I believe when I lie down on the bed, this person always faces the other side. Now, it may have some truth, but on these basis nobody can reach such a conclusion. Or some people believe that okay, government of India is after me. Now, this type of delusions are still into practicality. Difficult to decide what is happening unless you know the full truth. But for somebody, there can be a bizarre delusion, like somebody say government of India is spying on me. How? I know they have put a tower onto the other side of the road from which they are recording me, and I know it. And you ask them the proof, they will say, no, I just know it. Now, that is a bizarre delusion, unlikely. It is unlikely that President of United States of America has put in drones to kill me. Depends on who is saying. If a head of the nation is saying from somewhere, North Korea, then you may be. But if some villager is saying this, it is implausible. So, delusion cannot be decided just on what they are saying. It has to be decided on the whole context and knowing the rest of the history and background. And that is why all that information, demography and education and everything becomes very important in the background. Possession of the thought is like what is the thought process is, what is it possessed by? It is possessed by repetition, like in obsession. Obsessions by perseveration is another possession, as I said, possessed by that simple answer again and again, or an idea. Obsessions are repetitive thoughts from your own head, which are ego dystonic, that they are not in your scheme of things, which are anxiety provoking. Any attempt to stop them creates anxiety. They can be in the form of a doubt, like people wash their hands and their mind tells you they are not washed, or impulse. Suddenly this, every time somebody feels that every time I go to a height I should jump, or I should stab somebody, or I should touch somebody. Doubts, counting, some people keep counting unless on the number plate till they reach a certain number. The act which people do, the motor act, are called compulsion. If your mind keeps telling you your hands are not washed, you have to keep washing it again and again. Checking the door whether it's locked. If you are, some people have, when you're walking, you have to take 2 steps forward, 3 steps. Unless they do it, their mind will not be at peace. Magical thinking. If this is a hallmark of illness called OCD, which is becoming very malignant these days. Magical thinking is your mind keeps telling you that if you don't do certain things in a certain way, then something wrong will happen. So, they have to keep performing things. There is something called obsessive slowness, which is a need for symmetry. Like 5 things are kept on the table, they have to keep arranging it in a symmetry. There is something called ambivalence. Their mind keeps telling you, you have to act this way or this way, this way or this way. Perseveration, as I again told you. So, these are, by this phenomena you can immediately diagnose. If somebody comes and tells you that this is happening, and then you just have to take the demographic history, see since when it is happening, but you have to do a full examination which you get trained with time to know whether it is coexisting with some other illness. So, suppose somebody tells you that my mind keeps telling me things again and again, and you say it is obsession, okay, fine, OCD. It is not the right way, because you will have to also check whether the person is having along with it depression or existing of psychotic symptoms, or because psychotic symptoms by definition are a hallmark of psychotic illnesses, which means that mind is out of touch with reality, there is a lack of insight, and there is a presence of delusion or hallucinations. So, one has to rule out the other things. You just can't take one phenomena and make a diagnosis on that, otherwise it will be a huge error of judgment in treatment. Perception is like sensation is which goes through all our senses, and perception is the interpretation of that. Hallucination and illusion. Illusion is when the stimulus is present and you misinterpret it. Like for example, you are going in a dark, typical example, and there is a rope and you suddenly take it as a snake and get free, that is the illusion. There is a rope which your mind misperceived as illusion. Hallucination is perceiving a stimulus when there is no source there and the stimulus is not there, like you are hearing voices when there is no voice around, nobody is speaking, there is no radio, no loudspeaker burling away, no train passing, and still you hear somebody talking to you. So, what you have to check, if this is there, you have to check the modality, in which modality it is visual or auditory or touch or smell or content, what is the content and how much emotional disturbance it is causing. Now, content is like second person, maybe somebody is talking to him, this person, and saying why are you doing this, indirect second person, or there may be third person, 2-3 people may be discussing about that person. There is another type of hallucination called functional hallucination. The original sound is there, but that also, that as long as the original sound is going, there is another sound which is going on or a voice going on in the head, that is functional. Like a water tap is there and the water is flowing and you are hearing voices as long as the water is flowing. The reflex hallucination, that like if you see something, you suddenly hear a voice. So, stimulus in one modality can trigger stimulus in another modality. Synesthesia is when you feel or when you perceive in a modality which you are not supposed to. Like if you see a rose, you can still smell it, that is normal. But if you taste the rose, or some people like hear the color or see the sound, that is synesthesia. And synestopathic is what you are not supposed to know at all, like your stomach absorbing food, you are not supposed to, your brain does not register that. Your brain gets a feedback whether it is digesting or not, but it does not register. So, these hallucinations are all this internal thing, this is the discrepancy between what you see externally, the external input versus the internal imagery which is being created all the time. Now, this internal imagery is normally suppressed by the conscious brain, so that you are in touch with reality, but sometimes this internal images overpower what is being sent from the outside, and then if they are so strong that they create emotional reaction, then one tends to believe this and one tends to respond to this internal imagery rather than going on to the external imagery, and that is the hallmark of psychosis. So, a false fixed belief, delusion and hallucination is a hallmark of psychosis, but not all psychosis, people may not be disorganized, they may continue with their life and still be having delusions. So, and the last part is cognition, which you will know whether you are talking to the person, whether the person is conscious, oriented to time, place, person, because these are two signs of neurological illnesses, whether the person is able to concentrate and attend to what you are saying, because in organic illnesses or illnesses like dementia and other, say in withdrawal, lot of these things which are baseline for living, being oriented to time, place, person, being conscious, not consciousness in the sense of philosophical debate, but being conscious is being conscious of where you are, and orientation and concentration and attention. Attention you can check, you can ask, give 3 or 7 set of 3 numbers or 3 words and ask them to repeat it after you. So, if they are paying attention, they can repeat it too, or may 100 minus 7 go down serially. If the person is paying attention, they will be able to tell you. Calculations, memory, you have to check immediate, recent and long term memory. Long term memory is obviously their personal declarative memory, their address, and short term memory, you give them some words, some objects, objects for the visual memory, words for the verbal memory, and ask them after 5 minutes. So, if the short term memory is intact, the mind would have seen it, kept it in the mind and kept revising it, so that they are able to recall. Immediate is you ask, tell your name and ask immediately. So, if the person is not paying attention, immediate memory, it is very hard to exist, and short term memory losses are the signs of dementia, as we know. Insight is patient's capacity to acknowledge, to appreciate illness, associated implication and consequences. So, people vary from absent insight to full insight. Normally, a normal person, one sign is full insight. Now, at times when you are talking to people, you may judge that the person does not have an insight into what he is saying. A kid may be planning some high flying career without putting into the right effort, but if you probe deeply, the person would know. The person would know. Absent insight is a sign of psychosis. So, and judgment, you give him a situation and see what the person decides. If a person is on fire, what will you do? Or if a kid has fallen. These ordinary things where normal people will do normal actions can give you an idea to the judgment. So, judgment requires insight, cognitive functioning, other abstract ability, conceptualization. Abstraction is where you check whether people can generalize from things. You just ask differences and similarities between, say, proverbs or objects. So, differences people can tell, for similarities you need generalization, that conceptual thinking whether it is there or not. So, this is broadly an overview of how you do the mental status examination. Lot of it may appear as common sense, but some phenomena are specific. All of us, apart from the psychotic part of it, apart from the delusion, hallucination, lack of insight, suffer this range and reactivity and but normally people, when they are not ill, suffer mood changes for brief periods and they bounce back, brain bounces back to normalcy. Even a small thought derailments here and there are normal for most people, but they are all temporary, lasting for hours to maybe a day. Some of the illnesses can also last for a day, but gross disturbances, more sustained, episodic, continuous, they are the indicators of illness. But illness, psychiatry illness cannot be decided on just one phenomena. The period of that phenomena, the intensity of the phenomena, plus associated phenomena in keeping with the context and background of that person will give the real indicator whether the person is ill or not. So, I guess that gives you a broad idea about how we look at illnesses, and in the next lecture we will talk about how we have gone on to classifying the psychiatry illnesses and some of them the hallmarks of that, which will give you more idea about what is happening. Thank you.